In this section of our lecture, now we will discuss the investigations and management. The investigations we will talk about is the radiolucent foreign bodies, X-rays, endoscopic removal of the foreign bodies, and also cervical and transthoracic oesophagotomy to remove the foreign object. So the common investigations is the posterior or PA view and lateral view of the neck. X-rays are very, very simple and very helpful diagnostic test for or investigation done for the foreign object. If it's in the neck or in the oral cavity, very, very easily it can be seen by the help of X-rays. So posterior, PA and lateral view of the neck, you can see the foreign body which is present. Similar view of chest, including abdomen, we can perform and we can see the foreign body that is passed through esophagus, and now maybe it's in the intestine, in the duodenum, ileum, that can be easily observed also. Revealed radio-opaque foreign bodies which can be seen by the X-ray. So it can easily reveal radio-opaque objects. Their location, foreign body of esophagus lie in the coronal plane in PA view, edge on in lateral view. So if the foreign body is in the esophagus and we do the X-ray, PA view and lateral X-ray on the PA view, or if the foreign object lies in the coronal plane, but in the lateral view it lies on the edge. Reverse in tracheal foreign body. So it's reverse in the tracheal foreign body as we saw in the esophageal foreign body. What happens in the tracheal foreign bodies, radiolucent foreign bodies may show as air bubble. In cervical esophagus, in X-ray soft tissue lateral view of the neck. Failure to see foreign body on X-ray, not rule it out. Small bones, wood or plastic are radiolucent. So if we cannot see the foreign object on the X-ray, doesn't rule out that there is no foreign object. Maybe its location is in, it is located or it's too small and the site where it's not visible, or it may be radiolucent like bone or plastic. Radiolucent foreign bodies usually may appear as air bubble, may be in cervical esophagus, in X-ray soft tissue lateral view of neck. Barium swallow. Barium swallow is used for the diagnosis of upper tract, upper GI tract, which shows the esophagus and upper pharynx. We should do the barium swallow. It is avoided, may spill over into larynx, delay subsequent endoscopic procedure. So barium swallow, as I mentioned, it's very, very important procedure for finding any abnormality in the upper GI tract or in the esophagus. But it is, in this case, it should be avoided. Why? Because the barium may spill over in the larynx, or it may delay the procedure, endoscopic procedure, which need to be performed. Look for multiple foreign bodies, coins. Disk battery may elude may cast double shadow, stacked coin appearance. So disc batteries are the batteries which are used in the watches and different even different equipments like hearing aids. These disc batteries are very commonly used. So they make cast double shadow and they are stacked coin appearance. The management of the foreign object, we have endoscopic removal of the foreign object, which is removed by esophagoscopy. Endoscopic examination is when endoscope is used for the direct visualization of the foreign body, and then it can be removed. It can be esophagoscopy, direct examination of esophagus under general anesthesia. Both rigid and flexible endoscopes can be used. Rigid esophagoscope is used for appropriate for size of the patient with proper type of fossa. Flexible scopes, soft meat pieces without bone, vegetable matter are removed with the flexible endoscope or flexible esophagoscope. Blunt objects can be removed with the flexible esophagoscope. So these are the management steps. We can use the endoscopy, in which we have esophagoscopy. Esophagus is examined and then the object can be removed. It can be removed by rigid scope or by the flexible scope. If the objects are soft, blunt ended, they can be easily removed by the flexible esophagoscope. Endoscopic removal, hypopharyngeal speculum resemble laryngoscope with long blade, less traumatic, more convenient to use, foreign body lodged near upper sphincter. So we can use the hypopharyngeal speculum with the long end. They are easily more convenient to use, less traumatic. They resemble the laryngoscope and they can easily remove the foreign body which is present near the upper sphincter. Rigid and flexible esophagoscopy comparison. What are the different indications and why we use different rigid and flexible anesthesia? In rigid, we need general anesthesia. In flexible, we need topical or topical with sedation. Oral in both. Jaw neck abnormalities cannot be done due to technical difficulty, can be done. So if there is jaw and neck abnormality, rigid esophagoscope cannot be used, but we can easily use flexible. It is flexible and it can bend and go through the different abnormalities. Stricture seen up to esophagus, stomach, pylorus, duodenum. Again, if the strictures are present, we can only use the rigid one up to esophagus. Admission requires admission, usually done as an outpatient. Foreign bodies removal easy. Various types of forceps can be used. End of esophagoscope helps to unsheath sharp objects. Only soft, small foreign bodies can be removed with the flexible. Limited numbers of forceps that can pass through the channel can be used. Unsheathing of foreign body not possible. So we have both some advantages of rigid, some advantages of flexible, some disadvantages. So both can be have bad and good points. Accessories may require telescope for magnification, inbuilt facility of cameras available for the flexible. Cost is more for rigid, require admission, require general anesthesia, increased cost. Flexible has reduced cost. So both have some good points, some negative points, but overall flexible one is preferred because it is low cost. We do not require general anesthesia, easy to perform, and it can even be performed with some abnormalities. So these are some advantages. Cost wise, it's very effective also. Cervical oesophagotomy. Otomy is opening, so it's the opening of esophagus. If it's in the cervical region, we have esophagus is a long tube, so it has the thoracic portion and it has the cervical portion which is in the neck. So cervical esophagotomy, here you can see esophagus. This is the sternocleidomastoid muscle. We have the clavicle pectoralis major muscle. Impacted foreign bodies, those with sharp hooks, partial dentures, and it's above the thoracic inlet, we perform cervical esophagotomy. Require removal through incision in neck and opening of cervical esophagus. So otomy opening is performed, the foreign body is or foreign object is removed, and those objects are mainly the dentures and they are present above the thoracic inlet. Transthoracic esophagotomy, if it's lower down in the thoracic esophagus, then we, for impacted foreign bodies of thoracic esophagus, chest open at appropriate level. Stool examination daily for 3 to 4 days for spontaneous expulsion. Patient take a normal diet. Operative interference required when patient has pain and tenderness in the abdomen, foreign body not showing any progress on periodic x-ray, sharp object and likely to penetrate, pyloric stenosis, foreign body is more than 5 centimeter, passes through duodenum, disc battery more than 1.5 centimeter, remain in stomach for 48 hours in 6-year-old. So all these are the indications in which we should go for the transthoracic esophagotomy. If there is no progress in the removal of the foreign body, if it gets impacted in the wall, it penetrates, if there is pyloric stenosis, then if the object is more than 5 centimeter and disc battery more than 1.5 centimeter, we need to do the transthoracic esophagotomy. That was all about this section. Thank you for watching sqadia.com.